Thank you everyone for giving me this opportunity to present on this minimally invasive transthoracic esophagectomy, reduce postoperative pulmonary complications and international court study. I've no conflicts of interest to disclose. So esophagectomy remains curative treatment option for patients with gastroesophageal cancers. And there is an ongoing debate around the optimal surgical approach for esophageal cancer. However, there is limited data assessing the external validity of randomized trials on outcomes after minimally invasive esophagectomy. So there are two key papers that have been published looking at the role of minimally invasive versus open esophagectomy or hybrid versus open esophagectomy for cancers, two randomized controlled trials. And recently there is a paper looking at adoption of these minimally invasive techniques into routine clinical practice. However, they are variable. Therefore, global data comparing MIE and open surgery are lacking. So the aim of the study is to compare the incidence of postoperative pulmonary complications on open, hybrid, and totally invasive, and assess the rates of postoperative morbidity, i.e. overall major complications and anastomotic leaks, and 90-day mortality. We collected the data from the OesophagoGastric Anastomosis Audit Collaborative to identify patients undergoing transthoracic esophagectomy for cancers. This OGAA study included 142 centers from 41 countries. So this flow chart demonstrates the inclusion of patient. We had 2,247 patients, of which 1,698 entered the study. In the open group, we had 750 patients, hybrid 507, and totally invasive, we had 441. Now, across the primary outcome, the rates of pulmonary complications are significantly lower in those totally invasive. However, it's important to note that anastomotic leak rates in an unadjusted data is significantly higher with totally minimally invasive compared to anastomotic leaks in open or hybrid surgery. In terms of baseline characteristics, patients receiving minimally invasive were more likely to be from high volume centers, from high income countries, and they were much more likely to have higher ASA grade 3 to 4. There are no difference in clinical T and end stage. In terms of neoadjuvant therapy, patients receiving totally minimally invasive were more likely to have chemo-rad, and they were more likely to receive omentoplasty. And there's a high likely chance of no pyloric procedures being performed. In terms of outcomes, as you can see, there's no totally minimally invasive esophagectomy, significantly lower rates of pulmonary complications, and there were no difference to the rates of anastomotic leaks across these groups. So totally minimally invasive esophagectomy is associated with lower 30-day postoperative pulmonary complications, but it warrants a further review into causes and mechanisms in selected patients and the quality assurance and delivery of totally minimally invasive esophagectomy is of major importance. The ideal surgical approach remains unclear, and ongoing trials will provide more evidence within the few years that may clarify the optimum approach to locally advanced cancers. And that, thank you very much. I'll take any questions from the audience.